Yeah, I was asked to do a preparation in terms of how you use data to manage COVID-19. And I know that one of the words that you perhaps don't like, planners don't like to talk about, or IT persons or people doing policy development, is when you hear a term called fluid. And I have used that term often because managing COVID-19, it might be separate once you come in try to pair it with data, with the word data. And when data changes so frequently, then you realize that we have a serious situation that we have to deal with. As a matter of fact, just this morning, for example, I'm reading up on notes that in terms of COVID-19, people don't seem to develop immunity, which means that after you have had an infection for 3 to 6 months, you can get reinfected. So I have short slides. I try to make it brief so that in case there's any time for questions. But you mentioned the word infographic just now, and this is the infographic that I think people have started to familiarize themselves with rather quickly. And well, this basically, even though it might seem loaded, basically what this does is it tells us how many tests have been done, how many of those are negative, how many of those are confirmed cases, divides it by sex. And then the sex we can use that to do the recovered cases, active cases, and the total number of cases. And we do it by geographic district. The blue number is the amount of negatives done, and the red number, the little plus sign, is the positive cases that we have had across the country. This infographic is routinely completed around 3 p.m. every day. Once the information is coming out of Central Medical Lab, it is uploaded manually for the most part into an Excel file, and then that is reported as an infographic that you see here. And I can share what the background is to that. If I get the next slide. So all the data is generated by the epidemiology unit for the most part. That's at the Ministry of Health. That's made up of 3 epidemiologists, primarily biostatistician, data entry clerks. It is compiled with information from all the 4 health regions. We have one central, north, south, and west, and by surveillance teams that are active on the ground. These surveillance teams that are on the ground, made primarily by infection control nurses and public health inspectors, are what I call the real foot soldiers. These are the real frontline health workers, not minimizing the doctors and nurses, but if you note, most of our COVID-19 response has been outside of a hospital setting so far, and that is thanks to the work that the public health entities and teams have done on the field. So I think we have to acknowledge that. Whenever it's required, we do get information from private sector. All samples are processed in one central medical laboratory in Belize City, so they generate the data in terms of tests being done via an electronic platform. So that means that whenever I am swabbing anybody anywhere in the country, I upload that information into the Belize Health Information System. And once the result is out, there's a template that is updated in real time, and the regions can receive that information in real time. And then that is compiled at headquarters to produce that infographic that we have. So it's the team at headquarters that will routinely review, collate, and prepare that data for dissemination. Once it's completed in the form of an infographic, and there's a lot of data behind that, it will be signed off by my desk, and that's when it gets published for people. Sometimes the delay will come about when you have reactive cases, because you have to make sure that you have informed the patient or patients before we publish any data. So whenever all samples are negative, you can pretty much get that result rather quickly. And that's why you have infographics coming in at different points of time during the day, although ideally you would want it all to come out at 3 p.m. The next slide. And I'm saying this data sources that are available. This is actually not created by us. We had a similar situation, and you can go to the next slide. I just put this up as information because Total Business Solutions, I really don't know who they are or who's behind this, but they publish our data almost in real time. If you can go to the next slide, and they basically gather the information that we publicize, and then they do their own little curve, and they do recovered cases in a more visual, more vivid document online, and I believe they share this with the other Caribbean and Central American countries, and then they publish this online. This is information that's up on a template, and we can share where this comes up. But this is data that we give out to the public, and then they do their own internal dissemination process or on websites. Next slide, please. Yeah, so, and I'll give an example of how we manage data in real time, and I'll go to the more sounded off case in the last couple of weeks. Is the case of patient number 40 who shows up at the hospital on a Saturday. He is reviewed, the clinical data is plugged into the Belize Health Information System. That information system, in case people are not aware, the information that's plugged in there, it's replicated in real time across the country. So even though the patient was seen in San Ignacio, that data can be verified, or not verified, but it can be seen. Let's say the patient shows up on Monday in Corozal, the doctor in Corozal goes into the BHIS and pulls up the patient's information, and that is up there for them to see. So any facility in the public setting that has access to internet and the BHIS can see the information in real time if they were to require that information. So this person went through all the tests. They requested a COVID-19 test. There's a specific format that's filled. Some of it goes online. Some of it is done manually because of reporting mechanisms that are required for international agencies. So not everything is in the BHIS. That sample gets sent on to Belize City, and once the result is out, the lab will routinely, because it's a positive case, communicate verbally to the team in San Ignacio, and then they start uploading all the electronic templates that gets to me. I routinely don't get any particulars of any patient unless it's positive, and I don't need to have it because it doesn't help me. It helps the team on the ground that then goes out and does the case investigation. So once the team goes out on the field, they do take out a tablet that has a specific mapping mechanism to the GIS, because what they will intend to capture is this person, for example, is interviewed, his wife is interviewed, his immediate contacts, and then that data is plugged into a map so that you can, in real time, almost try to find out where he has been over the last 14 days as far as he can recall. And that data is then uploaded into a template which can be shared with teams across the country, and the communication is further asserted via phone. In this particular case, because he had been all over the country for 14 days, then your contact tracing element then can be a very expansive network, because once you go to, let's say, his contact in Orange Walk, you have to map out all those contacts from that specific area. So we managed to find out where he was in the previous 14 days in as much as he would recall. That information is mapped out, as I said, and that was shared to all the regions. So people in PG go and look out for patients in PG. And if there's a map that needs to be made for the PG area, that is done. Stan Creek, he was in Orange Walk, Belize, and Corozal. All of those entities get the map of where they potentially do, or the potential contacts. This contact tracing map has been done previously for HIV, but not with the wealth of information that is required for obvious reasons. We also do it for dengue. We map out on a GIS map dengue situations, and most people are not aware that we use spraying cycles based on the identified dengue cases in a given community. The fact that vehicles also have a GIS tracker helps. That's why we were able to ascertain that the vehicle that was on social media last week did not, in point of fact, cross over into the Guatemalan side. I mean, it stayed in the Belize border. So that's part of the work that's behind that infographic, which might not be much for people that are seeing it on the front end. Next slide. So where do we get our data from? Immigration, if needed. If we find out that we feel that you have traveled, we need to ascertain when exactly you traveled. Of course, no longer applicable right now because the borders are closed. But prior to the borders being closed, we could go to immigration and find out when the person left the country, when he came back, and where he said he was going. Police, in the case of border jumpers, provides information. Of course, this information is not routinely captured via an electronic situation. The teams on the ground do follow rumor surveillance. So it means if there's any rumor, border jumpers, people who are ill, we will go and look for them and put the information in the electronic system. We have information officer and education officer that monitors social media outlets for any potential thing that might be brewing out there. And we follow those as well. We follow media outlets, all the local media. We have, I think, my desk at least has a very good relationship with the media outlets in terms of providing information or potential tips of potential cases or networks, that is. Any network of any case, for example, the last patient number 40 had been basically scrapping metal from a major utility company. So we went to the major utility company. We may ask to review cameras, log in of when people went in and try to map out the area. So the real foot soldiers do this. Working closely with other ministries now, the police, human development, NEMO, so that we're able to provide information in real time from quarantine centers and all the other entities that provide information for us. And of course, the community, because contact tracing will only have value if the patient and the community provides the information that is something that you have to go back and verify. The next slide. And where, if I can get the next slide.
Marvin, I'll just give you a time check. We have about 1 minute left if you can move to your wrap up.
Okay. So the data ownership, it's really, data can be shared with anybody. There's only particulars of patients that you will not be able to get. But once you ask the epidemiology unit from the Ministry of Health of what it is that you require, we can provide that data. We'll only ask that you do cite the reference and that there is no misuse of that data. I can tell you that there is no legislative framework that guards this, so that's the reason why we sometimes don't provide data as freely as we would like. I think that's my last slide. The other slides are basically world websites. If you go through them, that will share information, our data. For example, the world meters captures Belize's information updated every 12 hours. Next slide. In real time, endcoronavirus.org gets our data in real time. Belize is beating the curve. Next slide. Yeah, so that's just samples. PAHO, the Johns Hopkins University, all of those entities get our information in real time, and then they provide that as part of a global template. Thank you.